My name is Marcy Doyle and I work for the New Hampshire Citizens Health Initiative. I'm actually a nurse by training and I've worked most of my career in practices, federally qualified health centers, ambulatory practices, and I've done some work for critical access hospitals. So I'm really excited to be here today. One thing about myself though is I have an ear infection. So if anyone's ever had an ear infection and your ear is full and you can hear yourself echoing, that's my problem. And so I hear myself really loud, but you just might have to say to me, speak up, or ask your question another time, but hopefully we'll make it through. All right, so we're going to talk a little bit about the site self-assessment. Now, who here has actually been part of taking the MEHAF site self-assessment as part of their B1? Can you raise your hand? Okay, so 2 people over there. Who's in a B1 practice? In an integrated setting, okay? Folks over there, got a few. You guys, folks over there, okay, great. So when you take the site self-assessment, one of the things I would often ask you is, did you take it with your behavioral health and QI team? And oftentimes the answer is no, someone else did it for me. I'm part of a system, maybe the hospital did it for me. I provide services in a co-located arrangement, but I wasn't I'm the behavioral health clinician, part of taking that survey. So one of the things I'm going to encourage you as we walk through this, and this isn't going to be all about data. This is going to be all about what it means to use some of these assessments, which we all use throughout our career, to actually improve and demonstrate behavioral integration that you're already doing. All right? Because we know that we already heard that you're a great IDN, and we heard there's lots of stuff going on. Now we want to show the world or the state what that stuff is. And one of the ways to do that is with your voice as part of that team. And so if you haven't been part of this and you are a provider, you are not only the medical director, you're a provider, you're a nurse, you're social work, you're a psychologist, psychiatrist, front desk, MA, data. If you haven't been part of these assessments, you want to find out who knows about them and how you can get partake in them, because you want your work and the work that your patients are doing to be demonstrated in those findings. Okay, so this presentation is going to really focus on 2 different areas. First, we're going to talk a little bit about, it's going to be fast, we're going to talk about practice in operational strategic alignment. I'm going to ask you a couple questions about that. Have any of you ever heard about the IDN 1 actually did a great, some great information in the beginning about SSA, but I'll just give you a little bit background. So the MEHAF is a tool that originated out of some chronic disease work for diabetes back in the early 2000s. And it has been used across the country in various states to look at integration and to be able to assess the practice as our site. So a practice is a physical location, and to see its movement over time. The tool, because it's been used so frequently, there's some value in the fact that you can do some comparisons with it. Most recently, actually, it's shown that if you have a facilitator, which many of you have as part of this work, you can measure some of the improvements from the beginning of when you started work to the end, or where you are now. So that's kind of valuable for you all. So one of the things that we're also going to talk about is, can you raise your hand if you currently do some kind of assessment for your practice? Meaning, do you have an assessment by the federal government, or you do a PCMH, or you have some other person come in or do something on paper to evaluate what you do? Do any of you? Okay. Okay. Anyone from this table? Anyone over here? So some of you, okay, do. So the MEHAF actually aligns with many of these assessments It aligns very well with PCMH. So those of you who have patient-centered medical home, those of you who have been involved in those initiatives, the practice or as an agency working with the practice, are going to see some familiarity. So we're going to also talk about when you use this framework. So the best thing about using a framework is it allows you to talk the same language, right? So if I'm talking about integrating new services within my practice, there's a dimension within the site self-assessment, a dimension meaning a question. The question asks how much of that service is integrated. Is it fully integrated, meaning I have, a practitioner in there doing warm handoffs? Is it less than fully integrated, meaning I have it some of the time for some of the population? So there is a continuum in these questions, and many of you may not have seen the questions yet, but it's on a scale, okay? So like a Likert scale. In using the questions, when you're taking the survey, it allows you to have that conversation with your team. So when you're having that conversation with your team, you're speaking the same language, and you can start to actually link what the IDN is doing, so linking the services that they're providing you, trainings, or you're providing your staff maybe on your own, and it's able to help you look at across time how those are impacting, how you think they're impacting. So if you were a practice and actually took a site self-assessment, it would look like this. We're going to have a bigger screenshot of that. So I just wanted to remind folks of the designations for the core requirements. So there's the coordinated care and there's the integrated care practice, right? So much of the work, it sounds like for the coordinated care, I think there's a deadline in December to have most of this stuff going, right? You're thinking about it, you're doing. Maybe it's not perfect, but we heard about West Central, and it sounded like some of the really great stuff they were doing regarding confidentiality and shared care planning. So you're doing this. It's not perfect though, right? And we all know that we wax and wane, but we hope our programs are sustainable, not dependent just on the changes. We respond to the change of workforce, say, but the program can somehow continue on beyond that. So, and the second is integrated care plus, so or integrated care. So that's all of that plus that. And so that's important because when the state put the waiver together, the folks that wrote it took key components of the integration process, and they decided through the IDNs they would fund them. But they didn't fund workflow, everything. Like they didn't fund what's unique to your practice, for example, workflows, or they didn't fund specifics. You got to pick some specific things that are unique to your practice, your service delivery model, your patients, to what your strategic and operational objectives are. So it's really great that we have this funding, but how do we do this after? How do we do this after the change, in resources? And so one way is we have to demonstrate it's effective, but secondarily, we need to build on what you've already said you're being assessed on, and you're doing probably pretty well. So I'm going to talk to you a little bit about a case study. So my role at New Hampshire Citizens Health Initiative is really to look at clinical and quality improvement and to look at it across projects. So many of you are involved in the Practice Transformation Network potentially, maybe your rural health centers, you're involved in the IDN. So one of the things that practices have, I definitely had this when I worked at a practice, was fatigue of quality improvement or fatigue of program rollout, right? So it was a big thing, please don't come again. I just can't take it. I've lost 3 nurses. So one of the things with working with a structure and trying to align it to our major initiatives, strategic and operationally, is it allows us to be working on the same project that we have already said to our community or our board, this is where we're headed, and not take on additional work. So this case study is a smaller practice, and we're going to talk about it in a moment and talk about compounding projects so that you can do work smarter and do hopefully some less of it, but demonstrate that you're doing it. All right, so some of the folks here are practice facilitators, and they work with you in your practices. They're the team table over there, some of them. So they're from New Hampshire Citizens Health Initiative. And what we do is behind the scenes, we're linking these efforts that you're doing with the levels of integration. So you can see over on the far right, you see some columns that say program elements or program components. And then in the middle, you see the SSA dimension. And then on the right, you start to see the levels of integration. So all of you that got your practice reports, that you'll see in a minute, had some kind of score on it. And it really looks towards a level of integration. So when you start to think about how we organize the work, and the work is going to be more organized for you going forward, I understand, because there's going to be more linking of these dimensions. You can see that there's some yellow areas that are the practice facilitator, and they're thinking about the work that you're doing. They're thinking about, okay, this is for coordinated care. And they're looking at the dimensions to align them. How do they align? How do I get them beyond just the questions? What are the steps to take to get screening done? Or what are the steps that need to take with shared care planning? And then correlating here with the levels of integration with the evidence. So this particular practice we're going to talk about actually started out at an 80. And I'm going to tell you a little bit about the practice. So they're rural, they're primary care, they have a high Medicaid and Medicare population. They have limited behavioral health experience, although they have an MAT program, which is kind of interesting. They have a provider who's the quality improvement leader who is not the medical director. And one of the interesting things about this is some of the practices that we work with have found that the medical director is often pulled in so many different directions. Putting someone in place that, the medical director is a part of it, but also a provider that has invested interest in quality improvement and growing them is building their some of their joy in the work that they do, and is also giving them some control over what may happen in their work environment. They have a series of workforce challenges. They have high turnover. I say high, but similar to other practices. They've had provider turnover. They had some recent changes in the nearby hospital that they work with. So they also do weekly QI meetings. And one of the strengths is early on, we started working with this particular team as part of another project. They actually had the full cohort of people who might take this assessment. So they had the front desk, they had the QI person. So it was very meaningful, and it was teaching these folks in talking together about what integration was, not only with the evidence, but within their setting. So this is their site self-assessment, and this is what you all, if you're a part of a B1 practice and a B1 team, if you're doing this work, you should be seeing this document. If you're not seeing this document but doing this work, you need to ask whoever's in charge to see this document, because it's telling you really what's happening with people that are, what's happening with your practice. You're saying to whoever gets this data, because the IDN gets this data, it's aggregated at an IDN level, that this is what we're scoring ourselves on the framework. So when you think about the site self-assessment, the Likert scale, it's on a 1 to 10, and a score of 10 is the most fully integrated practice. So that would be warm handoffs are happening. They have all the components in there. They're doing it all the time. They're doing it with all their patients. Versus you saw that the last practice was an 80, so that's on the lower level, maybe the third level, between the second and the third and fourth level rather. So as you go down, you can see that this hits highlights of things that you've already talked about, like for example, data systems and records. What does that mean in terms of sharing information, screening, on 1.2. So the domains there's 2 domains, and they're at the top. We don't have a lot of time to talk about them, but patient and family centeredness, this is more a clinical domain, and this is more your practice and organization. And you can see that as practices over time take this survey, they may say, we're really not as integrated as we thought, and that's what happened in follow-up 2 for this particular practice. You see they went from an 8, a 7, then a 5. I mean, that's okay. And you can see there's some variation in funding responses. So the more you take it consistently with the team that you started taking, the more consistent the responses were, and you'll have documentation saying where you fell. Right. So as you work through your plans for integration, this particular practice decided, I want to focus on a couple different areas. I know for our organization, training is really bad. They had a pretty good team, but training for us is poor. So they started to work on, what the training components would be, in concert with, other initiatives that they were involved in. So they worked on that. They consistently provided feedback to entities saying this is the type of training we need, and then they also offered it to their staff. So they started to work on things, and then over a year and a half, they went from a 4 to a 6. Still pretty low, but they're making steady progress. You saw on the previous, let me see if I can go back. They're consistently increasing. It's still not perfect, but they're consistently in their building upon that. They had multidisciplinary case review. They had done that already with diabetes patients. They actually selected areas and things to work on, screenings and whatnot, where they had already operated at a high level. So, for example, if you have a process, you're providing usual care, but your process for delivering and screening for people who need vaccines is amazing, or screening for MCHAT or whatever is amazing, then you pick that process, and that's what this place did. They picked these processes and they said, how do we do behavioral health integration within that? And they built upon it because they know at some point all these resources, it will be them, and the resources actually change or go away. Hopefully they don't totally go away, but that's what they planned for. It'll be the next thing that we're focused on. So this particular, they also focused on dimension 1.8, screening and assessment. And this was a hard one because, and this is a hard one for many practices. For mental health centers, it's often hard because the PHQ-9 and 2, they have different screening for patients with depression. So the workflow is slightly different. They may take it from the CANS and ANSA, which is a great way, there's some standardized screening that they do, is a great way to build upon already working processes. So this particular practice went through and they said, okay, I want to start depression screening. But I don't know that I want to start everyone. So they knew they were really good at diabetes, so they started it with patients who had diabetes. And then they rolled it out to the entire practice. So you can see here, when they started, they had a sub-component where they also started to think about, maybe we want to be a fully integrated practice if we could get the resources. And they said, geez, I want to start to think about those clinical care guidelines. And so they were thinking, if we have a score over X for the PHQ-9, what would we do? And they started pulling upon foundational work by Caton on collaborative care, and they started thinking, if we had a patient with a score of X on the PHQ-9, what would we do then? And they put in place various referral methodologies, because at that time they did not have behavioral health within their practice. So they had to work to do additional pieces of that. So as time went on, though, they removed the diabetes and they acquired behavioral health clinician, and they were able to see some improvements over time. All right. So the other thing that you all had talked about earlier is collecting patient stories. And also, I didn't include the staff stories, but this particular group actually started calling patients who had an elevated screening on different areas every 2 or 3 weeks. And it's a lot of what you're doing, or based on need. And the testimonies were, it's nice to be called to see how you are. And I would not have made this much progress if I did not have the help. So it sounds like you have those stories here, but as part of using the framework for the MEHAF, they were able to look at involving patients and getting elicit patient comments, because that's a trigger. When you look at the SSA, you see, oh, what am I doing for patients? And they were like, well, we need to start collecting more stories. So these are some of the quotes and stories. They also have provider quotes. One of the other practices that I work with has provider quotes. They always had people integrated, but it wasn't really functioning optimally. And until they develop look at past workflows, current state, and future workflows, they actually the providers didn't understand all that the clinician could offer. And so the comment at the end of doing a PDSA, Plan, Do, Study, Act cycle was, I didn't really know how much you could offer me. I didn't know that you were going to just come in and offer to help me with, do anticipatory guidance. You've been here a long time. I didn't realize that. And so and I think it gave the behavioral health clinician pause too, because they started saying, wow, I'm not just seeing these 40-minute appointments all the time. I can have an impact every day, and I can, and look at that over time. And I am learning what it's part to be part of that primary care team too. And I think that was a big piece for this particular agency. So I put this in. If you're in the Practice Transformation Network, and that is with a CMS. There's some CMS funding for that. You would know if you were. There's actually reports that look at how practices are doing, comparative to not being in the network, comparative to being in the network, and then their own practice. So this is claims data, and there's many, many reports. I just wanted to highlight one thing. And this can go beyond practice transformation. You're probably thinking about doing this here. So the orange line is practices that did not participate in the practice transformation. So that's similar to what we're doing here. The coaching, you're getting services from Mark and the whole team. You're getting subject matter experts. So this is all our practices in New Hampshire that aren't part of that. And then this green line is part of the practice transformation practices that are part of that. And then this is the organization. So I only brought this one graph, and this is actually commercial and Medicaid. So, but there were others. There were ER. There are measures that they're doing, EHR measures that you're going to be submitting through the portal here. So this one practice over 2 years actually has really made a lot of improvements. And I'm going to show you at the end some of the conclusions. They are actually, we just renegotiated a contract with a commercial payer for double-digit figures. Using the data, they can say the qualitative data, they can say the claims data. So it's a big deal for all of us in terms of hiring. And they were able to show these assessments. So there's 2 assessments for them. They had the PAT, which as a coach we would work to combine, and they did the SSA. So they're able to show that work. And so I would say to you that the work we're doing does make a difference. They have the same challenges. I mean, they were going to start a project and they lost their clinician. Their behavioral health clinician, they had to rehire. So just to re-emphasize, a team assessment, reviewing the data. So starting to review the data, your assessment data, then taking the IDN aggregate data and saying, where am I compared to the IDN? Where do I fall and why? Do I not have the same service delivery model? Is the EHR a problem? What needs to be done? Where am I comparatively? And then taking the clinical data, right? So what's my screening rate? Because some of those measures are standardized. Like we all talk behind the scenes to help make it easier. for the practices. So, you know, Medicaid, and to look at what those denominators and numerators being the same, and to line them also with MIPS measures. So if you're being paid on MIPS, you're submitting to CMS, that we have an alignment. The Behavioral Health Association as well. The measures may not be perfect, but it's a comparator. And it's a comparator if we all are looking at them for the state. Okay, so I just wanted to show you. So at one point we're looking at basic on-site collaboration. Then we're looking at close collaboration, some shared systems. And then still we're at I think they're at 117. So one of the things we noticed with the IDN 1 was that 22 practices took it on the initial, the SSA, and then 10 on follow-up. By the follow-up, it took it, only 10, which might make sense. I don't know the requirements in terms of who's participating, who's not. But one of the things that happened was that a lot of folks, the only change was 82 to 84, I think, 2 points. So what it said as a group when we met with the IDN members, they said, we are doing more. We're not sure what's going on. And so one of the things that happened is it didn't really reflect, even after we pulled out the people that didn't take it, it didn't necessarily, we thought, reflect what you had done. And when we at the Assistance Health Initiative looked across the regions from the state, so 1, 2, 3, 6, 7, it wasn't really reflective. And we thought that it was important your leaders thought it was important to kind of talk about that today and how you move forward with that. The importance of kind of showing what you're doing. And you speaking for yourself and not just having some of these numbers speak for you. So what was the conclusion for this particular practice? A 25% negotiate increase in major commercial contract, which was huge for them. Making steady progress with limited resources, alignment and maximization resources, so they align their PTN, their other work with what they were doing. They're graduating to an ACO. They are trying to adhere to weekly QI meetings or huddles very quickly. Some of them are huddles. Training and practice as it relates to evidence-based clinical guidelines to develop workflows, because there's always that feeling to revert to usual care. Usual care is what we used to do. There's always that, oh, well, eventually this will be over. And then obtaining qualitative feedback. So that's that in a nutshell. I don't know if anyone has any questions, thoughts. No? Crickets, you're already, you're done for the day?